So you're going to do really well in forensics. Yes, yeah. Because of all the people, forensic people, they end up seeing many different people. No, you'll be well. I've got still a couple of maybe 2 years ahead before I can sort of fly. So where would you apply? But they're going to have a forensic program? It does. So you would stay on, there's 2 programs. There's one here and there's one in Hawaii. And it's the same story for residents here. Either one here or Hawaii. Triplet. Yeah, triplet. Yeah. So maybe it's Hawaii is great. Yes, they'll make your life wonderful. And it's free. Yes. And I'm getting in trouble. There's a lot of pros and cons. It was a difficult decision for me where to rent. So where did you rent? I ended up renting this place first. It wasn't easy. The main thing I was trying to, the main thing I felt FOMO, as the kids would say now, is that they have an integrated VA hospital there, so you get to see people from the What did you want? My fiance is a lawyer for the United Nations. He works on anti-corruption engineers. I think she would have felt a little cooped up. Exactly right. Yeah, I do have a number in my over the career I've been working on. It's amazing how some people really get an iron fever, just that claustrophobia. So I love to visit it. In fact, I'm hopefully going there, for holding my fingers, pushing my fingers, the 25th of August, vacation. But I'm worried that they're going to close for 2 weeks. But I'm worried they're going to get out there, and since I haven't had a patient in 2 years, but I'm worried they're going to close borders because if you do get out there, the thing I didn't do, which I regret, is I didn't get to see any of the other islands. No, I've done Honolulu. The island I love the most, I've been on Maui. I did a lot of native Hawaiian work. So I really see Hawaii is my favorite island. The one that's least touched, it's still more natural. So when you do go out, it's a great place. Yeah, like Beyonce said, she's been all over the world doing NGO shows. She said it was the most beautiful place she's ever seen, but also has infrastructure. Yeah, no, that's true. Yeah. Even now, my sister goes there for a month in June. They retire, so they go to a place in June. It's Costco. It truly is. So you have the beautifulness out of the city. Paved roads, and people go there. It's actually well taken care of. A great place. And the indigenous native Hawaii, just amazing people. And you're looking at traditional substance abuse treatment for Native Hawaiians. We did it for Native Americans and Native Alaskans. A great project. They're just a welcoming, so you'll love it. You're just reminding me of when I was rotating there, and one of the on the morning report they said one of the psych companies messed up his room and looked way more on the minute we made. I was going to say, I'm sorry, what are you talking about? I said, oh, it's kind of like a Hawaiian. Right, yeah.
Just like
Almost so.
And I get down there, I'm not actually get that.
Yes, I like your sound. Later on, please use the name.
Not too late. You can say no. Okay.
I felt down a little bit. So I can do almost anything. Some of the like actual big stuff, I still have the same like balance sensor. And some of it I just can't. But it was the guy that came in with some Thailand stuff. So I was like, I don't know what you're doing over there, but I'm not sure how you're like, I did it actually.
Good morning. Welcome to the first grand rounds of the academic year. So I'm very pleased to introduce to you our headliner of the academic year. We have Dr. Saul Levin, who is the CEO and Chief Medical Director of the APA. Before that, he was, among many other things, he was also the Vice President of the AMA. I'm going to keep my introduction as brief as possible because the longer I talk, the less time he has to talk. So he did his graduated medical school at the University of Witwatersrand in Johannesburg, and then
give him a clap. You got it perfect. It's the first test of your reading that resume.
He did his psychiatry residency over stateside at UC Davis, and has extensive experience in the government sector, the private sector, profit, for-profit, and non-profit. And I will let him take it from here. I thought because especially in the military, leadership is emphasized a lot, and a lot of us, even if we don't want to pursue, say, the leadership or administrative track, we may get pushed into it anyway. So I think we could all learn a lot from him. 15 to 20 minutes I've talked to him before this. Well, without further ado, thank you, Dr. Levin.
Thank you. I really appreciate that. The fact that you're in the military, you're automatically leadership material. It's like I say to the fellows of APA, we have for the residents, there's a fellowship program that you're able to apply for during your residency. And I say that, there's some people who are natural leaders. And I do believe that, and I do say I did not serve in the military, because I would have had to go in South Africa during the apartheid regime government, which I wasn't, my family and myself weren't quite on track to do that. It's something I've learned over the years, that I've come into contact, that every military person, no matter what the rank, is a leader in their own way. And so this talk, in some ways, you may already know a lot of it, because I think you've experienced it, you are experiencing it. And having gone also through medical school and through residency, in some ways you become leaders to different, the different groups within the healthcare delivery system, but also to the patients. I mean, in some ways they come to you, like we often look to our leaders for really the help and the taking care and making sure that they're able to take care of you. So thank you for that. So I want to very quickly, I know I've been told, Saul, you spend too much time on thank yous, but to be quite honest, I feel they say put it at the end of the talk, and I say by the end of the talk, everyone's bored. It's time to get to your next session. So I really want to thank Lieutenant Colonel Raul Amin, the program director. I know I met him, he was here a minute ago. There you are. Thank you, for being the residency training program director, because in some ways it's a wonderful job, but it's also a thankless job. And I've seen many residency training directors because of the complexity of what they have to do. I also want to thank Colonel Wendy Waits, the outgoing Department of Director of Behavioral Health. I don't know if she's here or not, but please send her my regards. Colonel Ancieto Navarro, the new Department Director of Behavioral Health. Welcome, congratulations. And Dr. Stephen Nemchek for helping me put this in touch with USIS to do this. And last but not least is Captain Neil Gordon Clark, one for your assistance, in actually getting me onto campus, getting me through the hospital system. Very big. I said, well, that's just a lot easier to just get to, it's quick and easy on it. So, and I have to thank all the men and women in attendance today for everything you do. One, you do for our country, and for all that you do to keep our military personnel and their families healthy. So I really thank you for that. So very quickly, we now, as you know, in the new world, you've got to do your disclosures. The CEO, Medical Director of the American Psychiatric Association. I get all my income from the APA. I also happen to be the chair of the APA Foundation Board of Directors, as by the bylaws they have it. And that's our philanthropic arm of the APA. And if you haven't gotten involved with the foundation, really look at some of those programs. There are truly amazing programs going out into the public. And last, I'm at George Washington University School of Medicine and Health Sciences. I'm a clinical professor there for psychiatry and behavioral sciences on it. So today we're going to talk a bit about administrative and clinical leadership. And I'm going to talk about the role of us as psychiatrists and healthcare professionals. I know there may be some other healthcare professionals in the room, that we all in some ways at times get called on to do administrative work and to become a leader within the administration in terms of your role. I'm also going to touch a little on the role of our members and what APA does. Obviously, I want you, hopefully you're all members of the APA as residents. It's an important part. You get a lot of benefits from it. And I always like to say, maybe not as much for the military, but maybe so when you do finally leave the military, if you do, and you're now going to go into the private sector or the public sector, we have an amazing book there of how to go into private practice or when you leave your training. Because I always thought when I left my training and I was negotiating with the university that when they said the salary they were going to give me, that I thought everyone got that salary. In hindsight now, having read that book, that's not true. If they really want you because you have a subspecialty that they need a little more, they will pay you a lot more to bring you in there. So it's something, if you're going to private practice, it'll help you on that. So please, I'm not saying that you need to leave the military or you should leave the military, but if you do eventually in your career, maybe 30 years from now, you should still go back to APA and go and have a look at that book. It will be updated hopefully by then. So I think I'm going to talk I'm not going to read the slides, so please read the slides. I'm going to talk about what's on those slides to you. The first thing we have to realize as a physician is that you do need to become involved in leadership or to think that one day I will be called on to lead something, be it even a small group. Throughout our training, we occasionally go to groups and they're going to choose someone to do it. And sometimes you have no choice. I think sometimes it's very much the military way. You're going to volunteer, to do the job. But at other times, it's to see who really steps up. And I've got to tell you, every time I've stepped up, even though at times I didn't want to step up, it has only made me enjoy the work more. I may have had a little less sleep or a little more complexity in terms of what I had to do in the job, but I've always walked away saying, boy, that was a really good experience. I may have hated the experience, but it was a really good experience. And so I ask you, as you move through your career in the military, never turn down a chance to actually take that job if you have the choice. As I'll say, it's different if I'm talking to the public sector on it. We have to begin to realize that we are working in, no matter where you are, in some form of bureaucracy. And the bureaucracy clearly is not friendly, and I'll say it right up front now, particularly in the health system, to physicians, doctors, or patients. In some ways, to keep this whole center going, they've got to have a lot of money to keep the center going. And you are merely just one part of it, a very important part. And you'll see, particularly in mental health, and substance use, which is, I like to say, I used to say the stepchild when I was doing the addictions, part of my career. I now like to say the baby child. So you don't get as much money because it's all been used up by the time it gets down to us. We in the mental health field and substance use field are still at that sort of not where we're equal, and we'll talk a little bit more about here are both our patients, but it's all about the money. In the end, if you don't have, and I know this may sound very, cutthroat or very upfront, it is, if you don't have money to do the work or to have the opportunity to do it, that's just not going to exist. Now, we do occasionally in clinics, there are, volunteer clinics that you do it, but in some ways in a system, even like the military or at APA or at any of the universities, it does come down to how do we keep the lights on first? How do we ensure the building is there? How do we ensure we have the equipment? And we've then got to do it. We've got to have our personnel who comes into it. And I don't mean it in any derogatory way. It's just the fact. When the C-suite starts to look at things, I've yet to ever have, even in a medical association, do I hear them say, what we're about to do, how does that affect the patients? How does it affect our employees? It's, no. How are we going to get the money? Where are we going to put it? How much is it going to cost? Let's look at that spreadsheet. And it's the call I'm going to do to you. And pretty much if any of you have seen Hamilton, it's you've got to have a seat at that table and you have to take your shot. When you sit at that table, and we'll talk a little bit more in the talk, no matter if you're there as the medical director, they may want you to just talk a bit about medical stuff. You've got to say to yourself, I'm not just here to talk about the clinical medical stuff. I've got to talk about, you know what, I don't have enough beds, or I don't have enough equipment. So when you start talking about it and you get that chance to talk, you need to take it. And I think that's part of what understanding and accepting is just the small part of your career that you need to get involved in the administration part of it. Characteristics of physicians. What is a physician leader? I think we trained it from the moment you decided to go into medical school. When I went to medical school, I was very clearly taught by the dean at the time to say, when you chose medicine as a profession, you chose it in that millions of other people would never choose this profession. Who would think about, I want to dissect a body? It's just not the usual thing that someone would begin to think of doing. And they would talk to us about how you've already got a brain that wants to really explore, understand, and work out how do we learn what we need to know about that body, but then how do we need to take care of it? So you have a unique opportunity in any way. The moment you step into that room as a leader or as representing the clinician, that you have to think, how do I get my points of view across? Characteristics of a physician leader, I think you all know it already. You've got to have a vision. What would you do if you were suddenly given unlimited power to change whatever unit you're working in? You've got to begin to start thinking of that vision. You've got to have the commitment. And I think each and every one of you in this room, each and every one of us in this room, have a commitment to taking care of our patients to the best that we possibly can, and getting the best knowledge, getting as much knowledge as we can to ensure that we're keeping up to speed in terms of the vast changing knowledge in the country of medicine. And you're going to make that commitment, and I think you've made that. Collaborative spirit. There used to be a hierarchy when I went, and I won't tell you how many years ago I did my internship, but there was a hierarchy. The interns were at the bottom of the hierarchy. The nurses had a separate track to the physicians, and in some ways there was really no collaboration. in today's day and age, because of the complexity of medicine, because of the time, the volume of patients, and the expertise that you may need, we have to work in a collaborative environment. And I think you of all, and this is where I say once again, you as military or leaders, because you're taught that from day one. You have to, within your squad, within your team, you have to be collaborative. You all have to depend on someone else to be able to do your job, and you hope that they're going to depend on you to help them do what they need to do. So that collaborative spirit still needs to happen. In the healthcare delivery system, it's not working as well as what it should. We have a lot of turf battles. I constantly spend my time fighting for the turf battles of psychiatrists in this country. And it's not just, I'm going to say this, if they're psychologists, nurse practitioners, physician assistants. I'm glad my best friend, in fact, he was my chief strategy officer, just went and took over as the CEO of the American Association of Nurse Practitioners. You know, we still talk to one another. You know, there are turf battles that we have to begin to assert ourselves in. And I'm going to talk a little bit about that. And you're going to find it even when you go through the different hospitals in your medical rotations. You know, how is it that the surgeons, you know, seem to get a lot more money, that the internists get a lot more money, and that the mental health units, if they're in the hospital, are not in a very central place, sort of put aside, put away, you know, that takes us away. And we've got to work out how do we begin to tell them, you know, that you need to begin to work collaboratively and put us all together. And I think that's where leadership steps up in terms of education. You know, I very quickly learned when I did my dissection at medical school, I had social workers with me, you know. And you would think, well, why would social workers dissect the body? It was just part of their training as well, to get to know the body, you know, on it. And I learned very quickly that, boy, a social worker's job is as critical to me, and I particularly learned when I went to my internship and my residency, you know, in how do I get that patient out back into the community. I couldn't do it all. I didn't know it all. So I think that's part of where that collaborative spirit needs to come. And then education. You know, we've got very strict rules and regs now. You've got to go through your education, do all your exams, become board certified, continue with maintenance of certification, you know, and I'm sure you'll hear from some of your other colleagues about the anger about maintenance of certification. You know, why is it that we're forced to do this when some of the other parts of the healthcare system doesn't have to do it? But in the end, it furthers our education. I know I read those journals. I may not be doing clinical care anymore because I want to see where is medicine going? What is the best treatments now? So when a patient calls me up, or when a family member calls me up and says, I've got this patient, I'm able to say, sounds like you need this particular type of psychiatrist to go and see versus that. So who were my heroes? You know, that showed me that administration, you have to fight the fight, but you also have to do it both in terms of your job, but also in terms of a larger system. I'll say Nelson Mandela was the key person. You know, I met him twice in those, I'll say the first meeting was literally 2 minutes. The next meeting was when I was doing another job where I had, I think it was like 17 minutes all alone with the man, you know. And it was just amazing, just even being in his presence and just listening to a man who had spent literally over 20 plus years in jail, never lost hope. You know, I think in that whole, if you read his book, he lost that. And he always had, when you asked him or when you talk about it, he had always said, no matter how bad things get, you know, you've always got to keep your eye on the prize of where the good part is going to come. And I think that's what leaders are supposed to be about. Is through tough times. We've all now gone through with COVID, you know, what now, almost 18 months. Now with the Delta variant, we are clearly, I've just had to tell all my staff that you do not need to come back to the office again. You might as well just stay at home because the district, as you know, said you've got to have masks on all the time. And, you know, we're getting tired of it. You're getting tired of it, I'm getting tired of it. You know, even as I stood here, I thought, do I keep my mask on, you know, on it? I am fully vaccinated. I promise I test often, you know, on it because of the talks. And I think we have to take inspiration both within yourself and who are the people who have inspired you. Bishop Tutu, you know, Here was a man who was in the forefront of the struggle, from the religious side, that had horrible things happen to him. They never put him in jail, but on it. John Talbot, one of our icons here in psychiatry coming out of the Maryland area, was the president of Maryland. Truly was one of the first presidents that basically began to say, we need to organize in a way that will ensure that psychiatry going forward. He was a leader. And I can go down a whole bunch of people. Ezra Griffiths, still alive, one of the leaders today in Black psychiatry. Truly, when you listen to him, you understand, sort of the tough parts he had during his training, but he's always said he kept his eye on the prize of what is good for both me, for the Black physicians I was working with, but for also every other color of physician, that we all need to realize we all take care of every patient. And if you don't begin to become familiar and understand what someone else's social determinants of health is, you're not going to work. If you ever get a chance to listen, if you go to the annual meeting, go to his talks. They are inspirational and you will learn huge amounts from him. So physicians are experts in taking care of patients. I mean, we're trained to do it. We all know it. We may sometimes have little hiccups, as I like to say, in the British system. Yeah, oops, we didn't give as best a care there, or that's why you have hopefully go through your internship, your residency, go into a fellowship, and then have attendings with you to help you in those hiccups. But that doesn't translate into administration, into the leadership that one has to have once you're out of the clinical area. So I want to tell you about a 2019 study published in Healthcare Management Review. They found that physician-administered hospitals had higher ratings, quality ratings, across all the specialties, and more inpatient days per hospital bed than any other non-physician-led hospital. And the issue is, to me, very clear, and I hope it is for you. I hope it's not in your system as well, but I have a feeling, and sometimes you have a limited amount of beds, you are being pushed. Come on, the person could go home, or let's put them to the next phase of their rehab. But we are trained to look at the illness, work out how long it's going to take for them to get well. I broke my ankle doing something really stupid, and I remember the surgeon saying to me, I said, well, okay, so you're going to go and do your surgery. What's the recovery time? He said, well, it'll be about 2 months. You'll really not be on that foot, on that ankle. After it'll take, by a year, you'll be perfect. Well, a year, he forgot about the DVT that I got because I was lying in that bed for 6 weeks. And as I like to say, we as physicians have to begin to remember that while the person is in our care right now, you know that there are going to be some sequelae of whatever they came in from. And in psychiatry, it's just as much. Relapse, not taking their medications, going back into an environment that is not positive, particularly in addictions, where if you're an addict and you're living in a place that is just endemic in terms of addictions, sending you back into a place is not going to keep keeping them dry, sober, and off the drugs. And we need to know that, and that's what makes us different is when we go into the C-suite. Because I think of it, every decision I make at APA or has done through my career has always been, what's the larger system in here that this patient or this person or this clinician is going to have to face on it. The Mayo Clinic, I think that's the key if you go and look at it. The website of the Mayo Clinic, if you go onto it, it is a fascinating site, widely regarded as one of the finest hospitals in this country and certainly even in the world. People fly all over to the Mayo Clinic. Notes that it is physician-led because this helps ensure a continued focus on the primary value of the needs of the patient comes first. And I've got to tell you, you go and talk to now the CEO, medical director of the Mayo Clinic, He sits in that boardroom and they start saying, well, we only have this amount of money. And you have your CFO, you have the other folk in the room who are looking at it from their perspective. But it's that physician part of him that says, or her now, that says, you need to, understand that while it may sound good to you and really easy to do, we've got to remember that the patients have to live in that system and it's not going to work. And I think that's what we need to all say to ourselves every day of your lives. When you step into a leadership position, you've got to think not just of the immediate problem that's right before you, but what are the ripples that come afterwards, and particularly in the health industry when they leave that hospital, when they leave your clinic. I think peer-to-peer credibility, being able to walk the walk, talk the talk, is really important for all of us. You've done it. How many patients have you seen by the time you finished your medical school, by the time you finished your residency? You have actually walked the walk and talked the talk on this. You've taken care of those people. You now need to go into that C-suite or whatever. If you sit on a committee in the military, in a healthcare system, you've got to always remember, I need to think, how is this going to affect the end product of it, if I can call it that, which is the patient, and you make a lot better decisions and argue for more money based on those decisions. I mean, that's what I spend a lot of time arguing for, is that, excuse me, we have a fair amount of money. Something's just popped up here. Yeah. Oh, what is HLTA latency? That's resolved mean? Or something new I can learn from you as I walk out of here, right? Does that mean it's been too long? I haven't touched the remote. Yeah, on it. We need to, and I think that's what you need to do every day of your training. I don't know how we're doing on time. I often forget it. Greater emphasis, what should we do? We need greater emphasis on administration and management needed in medical school residency training. And I think that's what you should be asking your residency training director. You should be asking your chair of the department. You should be asking the system as to, how do I, I see what the management is doing. We talk a lot today about transparency. And in some ways, those C-suite offices and those committees that always get held somewhat in private, it's the rarity for you to see actually, well, what was the discussion? Who stood up and actually said, that's not going to work? Or who didn't, who should have and didn't? And I think that's what we've got to start remembering, is that that's what we are, that the clinical knowledge does not make up for the lack of managerial skills, and that's the one lesson I say to you. Take a course. Now you can get online, you can look up, courses on anything in terms of management and do it within a half an hour. Think of doing that, because it'll really make you think differently, particularly when a patient comes in to see you. And it is amazing how long have they sat out in that waiting room. So they come in, and when they tell you their story, and they've been out there for, let's say, 45 minutes, even though they told them they had a 9 o'clock appointment, and then now they're only getting to see you at 9:45, and yet they've got to go back to their jobs. They come in, and the way they present you is going to be very different to had you seen them right on time. Because it was, and I think that's what we have to start telling the administrative system that we set up on it. Budgets, where are we in the budget? Mental health, substance abuse, I hate to say it, is always the bottom of the run. There's the law with parity law in this country that was passed now almost 15 years ago. We're still fighting parity. We've actually just had to get another piece of legislation put through, and it was finally passed, to say that, you know what, the insurance companies cannot discriminate on when a psychiatrist does something to an internist. And I'll give you the prime example. So for an internist in private practice, and you as a psychiatrist in private practice, a patient comes in to see you. They say, doctor, I'm depressed. You can say, okay, let me do a full evaluation of you. Why is it on that original code, maybe not for you in the military, but once you get out there, that the code that the internist puts down, 25033, for that evaluation, and the psychiatrist puts down that 20533, why is it that the internist gets paid $30 more than the psychiatrist? In essence, I'd rather pay the $30 more to the psychiatrist because we're going to recognize this is not just a run-of-the-mill depression that someone's coming in with. The family practice doc is not going to look to that. He doesn't have that depth, or she have the depth of knowledge. And they also have the 9 minutes of seeing the patient. That they know the nurse is going to come knock on the door. It's time for you to get a move on. So, why is that still to this day? It's pure stigma, it's pure discrimination, and the law of the land now is that you've got to have parity. And we are actively fighting now at APA on the Hill in the states with the district branches. So get involved in your district branch. Actually, the military does have their own district branch. You have an assembly rep, 2 assembly reps that come to the assembly, our house, our Congress. And we are constantly fighting it. We finally gotten a law passed with money actually just put into this Congress, just finally passed the first part of it, that the oversight organizations in the government, had no money to actually go and see what exactly is going on in the insurance companies as to how they're doing in terms of their prior authorizations for psychiatrists versus prior authorizations for internists or family practice docs. And it was not me that did it. It was the individual psychiatrist who would come to us and say, you've got to do this. And we would help them go to the powers that be it within their hospital, be it within their legislature, to say, you have got to change it. They now have just gotten, I think, something like, I think it was about, $100 million, to now hire more staff a year, that they could now go and really look at what the insurance companies are doing in terms of their billing. And it's not just the insurance companies, it's Medicare and Medicaid as well. It's the feds are doing it as well. And I think that's where you, as a clinician, but also has that knowledge of, boy, I've still got to keep my practice open. I've still got to keep the doors open, and therefore I need to be paid fairly. It's a rapidly changing healthcare landscape that we have to adapt to. I came out of the collaborative care model. When I was in the federal government, I was given the wonderful opportunity to do what was then called the second integrated care collaborative care initiative around the country. I gave out millions of dollars under that program to clinics around the country to say to the primary care doctors, we will give you this money to start a new clinic, but you have to have the mental health folk, all the mental health groups, not just psychiatrists. You have to have the social workers, nurse practitioners, the psych nurses, in that clinic that will essentially help that patient overall. And the landscape has changed for us. We are no longer isolated to ourselves as psychiatrists. We now have to work in the systems. You do it every day, so in some ways I'm preaching to the choir. May not be perfect in the system yet, but it'll eventually get there. And that's where we as leaders now have to begin to move the field, to make sure that our physician colleagues see us not only as equals, but also adding the value that will take time of them having to see some of the patients that we can't see. There are about 50,000 practicing psychiatrists in the country, roughly. The AMA database isn't quite up to date, so it's a rough estimate. APA has 37,600 members. We lost almost 1,000 over the COVID period because many of our practitioners, of our psychiatrists, were told, we're closing your ward down and just go home. No salary, no nothing. I hope we're going to get them back once this all comes back to normal again. But the bottom of the line is we cannot take care of everyone in this country. You can't. Jürgen Unitzer, who started the collaborative care model, once said that if you had 50,000 psychiatrists in this country, there are 340 million people in this country. Well, if you wanted every one of those people to see you, that patient would have, I think it was 4 minutes in their lifetime of seeing you. Now we'll add in the psychologist, the scope of practice battle that we have on prescribing. Yep, I believe I went to medical school. I did my in South Africa at 6 years. You do 4. We then went to our residency training, which was 3 to 4 years. I then may have done subspecialties. I come out of there, very different in my knowledge of education. Some of the other clinical practices, nurse practitioners, nurse assistants, physician assistants, don't have as much training as we do. They do wonderful work, just as we do wonderful work. Yep, occasionally some of our psychiatrists are not the best in the world. They get into trouble, and it's the same with every profession. But the bottom of the line is that we have trained to look out not just for that average depression, the average anxiety or PTSD. We're looking to be trained to see what's a lot deeper in what you're being told right there. And that's what we need to be paid for. That's what the fairness needs to be in terms of how we get seen by our colleagues. And I do believe we're going to get there. I think we've spoken a little bit about that. The budgeting is where the organization puts its money, where its mouth is. You follow the money, you're going to you want to get into the administrative side, you need to get another degree. This is not your end. I had to finally say, after I worked in the federal government, that it's time for me to go back to school. I chose a Master's of Public Administration because I always believed in working in the public, the public field, and went back to school and got it. And there, trust me, I struggled a little on the financial spreadsheets. I did. It's like, oh, wow, this is boring like hell stuff. But you had to do it. And now in my job, every one of my departments bring me now their spreadsheets, and I've got to now work out where they hidden the slush money, because the board is telling me I'm going to cut my budget. And that's something I'd really say to you. Think about, even if it's just taking one course, early entry course in administration, in leadership, in financial management, do it. It will help you overall in your career, because no matter what happens, where you are, it already comes down to who's going to pay for this and how much is it going to be. So I did go back and get that. Changes in healthcare delivery demand leadership. Physicians are well suited to this role because we've done it throughout our careers. We've done it from when we were medical students to the residents to faculty to going out into the private sector. Non-physician administrators who have become the key leaders in terms of the healthcare delivery systems, because the physicians were too busy doing the clinical care, need to say, we need to get back into that field. And it's why when I look at the National Council on Behavioral Health, that has medical directors in all the behavioral health clinics around the country, or the community mental health clinics, or community health clinics as a whole. The one big thing they tell us, constantly I hear it, is, we've now been mandated, you've got to have a medical director, a mental health medical director. So they'll come to you and they'll say, you're the right person for the job. And they'll say, no, I'm not the right person for the job. I don't have it. No, we need you. And they keep complaining to me. We're there in name only as the medical director. They'll ask us some clinical questions, but when we sit in that room and they're talking about how they're dividing up the pot of money and the resources, and I open my mouth, they say, no, you're just the medical director. You just do the clinical side. And you've got to have some other thing to say to them, excuse me, I'm not just the medical director. I have some training in this. I need to look out to how do I keep my doors open in a way that patients come in and feel as respected as any other door they go through in the healthcare delivery system. And that's why I urge you, seek extra training on that. Who's going to decide the future healthcare system? I believe, and it's my personal opinion, not the APA's opinion, although I think a majority of my members may believe it, we are inexorably moving towards a national health care system. This country is too big. We just don't, the public sector is not going to be able to do it. The private sector, has the money to do it, but they're also making that money to enable them to do more and come out with profits. We're going to have to create some system of a national health plan. Will it be like the British system? Maybe. The British system does have a shadow private sector. Once you finish your duties, or you're now allowed to see X amount of private practice. Will it be the French system, the German system, the Dutch system, the Swedish system? All of them have very different ways of doing it. But I do think in the end, and I think you are in some ways the prototype, because you're having already to just work with everyone else because you're a closed system. But within this healthcare system, we are going to change. I know when I sometimes talk about this, when I go to the general membership, I get a lot of pushback. Is, what do you mean you're going to do away with private practice, fee for service? 20% of my members have. Forward. This system is going to change and we're going to have no options. The question is, are we going to be at the table? The administrators, the legislators, and let me tell you what I can. I mean, he has changed the way the way we do education today. If you go to our annual meetings, it's not just go and sit in front and listen to someone, go on and on like I'm doing now. It's innovative, it's active. How do we within psychiatry do? Psych, I have to be careful now, I'm going to get myself into trouble. The psychoanalyst is so complicated, and that's where a lot of our medical problems are. And substance problems are. If you come to the headquarters, there's a board with this bit of psychiatry. There's really have the one particular thing there's issues with contest and understand. One day in his career, he has 3 lines of, I swear, 3 lines of investigations of what he's doing. And one of them is where he will take a cell, inject it with a virus, I think he's going to kill me because he's going to say, Saul, you're corrupting my whole knowledge of what I'm talking about. And what it does is in that cell, that particular virus is putting in there is a serotonin producing cell, but it only responds to light. So when you shine a light, you know, when you shine a light, it goes into your eyes and it goes into your brain. That will automatically stimulate that serotonin cell to start producing more serotonin. And I think that's what we're going to learn within psychiatry. Yeah. So I'm going to say the last why did I put this slide down is because I very quickly realized as much as I loved psychiatry, I loved the clinical care. I actually liked doing my primary specialty was going borderline personality disorder and narcissism. I used to have borderline and narcissistic groups. And so, oh my God, how do you quickly go through a group like that? I used to say, you know what? It's literally a fancy match. Yes. And in the end, you try to get the patient through. But in the end, it became very clear to me that my skills were really in administration. It was seeing large systems and how to change the large systems. I am in my whole nature, you'll say about painful failure. If there's something that he sees, this doesn't work, there's going to be a better way. I'll go look to do it. So Samson gave me that opportunity. You know, I was discussions with our health administration, and I was there at this Advocacy. And they gave me this opportunity to do collaborative care. And in some ways, I look at clinics now across this country, and I remember they don't remember it anymore. But I was the one, or as Sam saw, the HHS was the one, who gave them that $2 million to start that clinic, to start that clinic. And that's when I realized the power of government and positions within the government, of leadership positions. Then we went on to Access Consulting International. That was when I left the government, after I came back from Cambridge, after my MPA, I started a healthcare consulting company, both the government and also the private sector. And there very quickly I actually realized there are two different systems in this financial systems. The government had very set rules how you have to work, but you learned very quickly how to play within those rules, so you got the maximum amount of money to do the project. In the private sector, you get in already, you know, you've got to outbid whatever you think they're going to want to pay you, you go double with it. And then you began to realize that is what management of a company is. And then it came down to this sort, was the company profitable or not, but doing good care. NCC education was the leader of NCC, Medical Education for South African Blacks. Some of you may remember Secretary Sullivan, Secretary Sullivan with HHS. He actually was the chair of that board after he finished being the Secretary of Health and Human Services. And this was an organization started by two Americans in South Africa. One was, I think the Shudder Fair, or what they called it. I truly believe it was CIA. And he told me his first stint, it clearly was CIA. I can't be going in there, from under the guise of it. But when they would try it, I said, what should we do? And the next was better no. And he realized that had he not been white in South Africa, he would have died from it. And he started this organization, he went to the deans of different medical schools, and said, what could we do to get more black students into medical school? And they said, we need money, because the government won't pay for black students to come into medical school. And out of that, by the time I took it over, we were given 20,000 grants from the life of that organization. I'm not just talking one a year. If you came to medical school, we pay for you from the first year of medical school all the way to your graduation. And Mandela used to say it, and Bishop Tutu used to say it. And if not been for this organization, we would have had to stop and spread this big development to nurses and psychologists and even radiology technicians. And instead of not been for that organization. And you saw how both the private sector can help the public sector and help the organization really begin change. And I think that's when the next part of my leadership in the treatment was. There is a book that's about to come out if you're really interested in psychiatric administration and leadership. There's a I don't know about the group for the advancement of psychiatry called GAP. It's actually a group that I think in the 40s broke away from APA because they said they weren't doing the right thing. And it's a think tank. And if any of you involved in it, you should become involved in it. Yeah. Thank you. And what committee do you sit on?
Just consulting on military advocacy.
Great group. When they said you want to join, I thought, I call them. I don't have time to do all the joining. It's the group I love to go to because they are a think tank. They've come out with a textbook of psychiatric administration and leadership. It's the 3rd edition. It's about to come out. So if you are interested, go for that book. Health department, I'm going to very quickly go through this. My best job, aside from research, was the health department. I was one step away, one touch away from actually helping people in the district. The mayor used to insist that we do walkarounds. We do walkarounds once a month in the different wards, and not in the safe parts of the wards, but in the wards that we're really struggling. And you've got to really see what is it I need to do and do differently. And I could go back to the Department of Health to say, we're not doing it that way. We're not being user-friendly to the people in that area to get them the care that they need. So I know we're running out of time. I'm not going to talk about the other side of me. So I think in healthcare advocacy, it's our duty to represent our patients. APA is there to try and get you better payments, to advocacy, but for each and every one of us, it's the patient is why we're here. And that's why we need you. We need the military. It's why we do have you as part of the assembly. To bring in more perspectives of what you experience on it. We've had some recently that I've said to you with COVID, it became very clear. An organization that basically psychiatrists literally said we have to see the patient in person. And I said, really? I once had the example where there was this committee that was selecting people to go into the hills and become fellows. And they had to see the person in person. And I said, well, why? We've now got Zoom, why can't you just do that? I said, well, just in case they're showing their anxiety by tapping their foot, I can't see it on Zoom. And I remember thinking, I hate to tell you, you just lost your case with me. Because if you have to think about, you're going to see the person's foot tapping and you can't see it in their face or in the questions you ask them, why are you even sitting on this? And let me tell you, the Zoom where I had, I'll say 80% of my members did not want to leave that one-to-one in-person practice. And literally over 2 months, I had 96% of the psychiatrists in this country moving to Zoom. And they don't want to go back. Now I'm going to see and they don't want to go now. I want to go to CMS, Center for Medicaid and Medicare Services, who now want to start saying we're not prepared to allow those rules that we basically said, don't worry about. We say, so what? We now want everyone to go back to those offices. You know that people turned up to the Zoom. How many no-shows do you have because suddenly something happens and the patient's out there don't show? That did not happen in Zoom. So we have to begin to start saying, I didn't realize that 3/4 of this country actually still are on telephone and are getting themselves not through TV, but through radio. It was a shock to me, particularly in rural areas, because there is no bandwidth in rural areas. So what are you going to do? Land down and they can listen to the radio. And we should be able to, on a telephone, still be able to give treatment for the same amount of money, as if I was doing it to a Zoom patient or as I was doing it to an inpatient person. Why would they change? And that's what I now spend my life now doing. It's the administration of how do I make more. So I'm not going to go through this. I'm sorry, I know I will talk. I always say to them, they write me a great speech, and then I start going off into tangents. I'll have to send you the slides. The Affordable Care Act is in flux. I do believe that, as I said, we need extra people ruling it. I want to say, like the military system. We take care of everyone. If you call there, we are moving to that. We will always have a side practice. Parity laws, we're slowly winning. If you are an activist and you do like to go talk to your congressperson, I know with the method that certain people need to be part of it. So maybe we could finally go back into civilian life if you do. Really go, because you bring a perspective that no one else brings. So with that, I'm going to end there and say I'm happy to take any questions you ask, but I do want to say each and every one of you, at least promise me, you'll go and look at this on the web. Is there a 101? So what's the key points that I need to know if I was told you're going to create a program and administer it? Just learn what are the issues that has to happen. You may already do your curriculum military training, I'm thinking you will learn what you have to do to do your jobs. But think of it from the perspective of you now making that decision. And what do you think they're going to have to do, and what are the people that I'm talking about to say, no, I want to do something different. I'm happy to take questions.
Yes, sir. Mr. President, the first question is I'm just wondering if the need for some kind of impact is long-term.
So it's a two-edged sword. I'm going to answer to your question. I believe our prisons and jails have become the mental health hospitals in this country, and the data shows it. Because, and it did start off with Ronald Reagan, when he closed all the mental hospitals in California and said, and he promised he'd take all the money that they were giving to those mental hospitals and put it into community mental health centers. Unfortunately, that never happened. And then you have, how many times have we seen, we've seen it, just look what happened to George Floyd. I don't want to get political on him. But you know what? There was something innately wrong with that young kid who was in the park who had a toy gun, and the police came, and I listen, I wouldn't want to be a police person in this country. But you would at least think that they'd have enough training in mental illness or to begin to identify that this is something a little more, and that's what's happened in this country. It's easy to very quickly say you were drunk, disorderly, take you into the prison, take you into the legal system, and put you into prison. And that's part of our problem, is that we've seen those prisons as the mental health hospitals and substance abuse hospitals of our time. And even there we're failing. There isn't just enough money to take care of them. Let alone that 90% shouldn't have even been in there. Going back to the old system, the country is not going to do it. The amount of infrastructure and money, is just not there. So I think in some ways we're going to have to see how do we bring both the public and private sector where everyone has to play a part in taking care of everyone. And the only way we can do that is to create an equal system of payment, where everyone gets the care, and it's paid for. I don't know if that answers your question. It's no country has gone back to the old 20th century way of where there was a private practice that you could just do it and you took care of a certain population and the others went into the public sector. The boundaries have so merged now in terms of care. And I think COVID showed us that as well. That really showed us the weaknesses in our health system. Because we just could not. Right now with the variant going on, our hospitals are already beginning. How many psychiatric wards were closed down to become COVID wards? We need more hospitals. We need more systems to take care of everyone. I don't know if that answered your question. I'm able to talk more. Sure.
As psychiatrists, we're doing a lot of disenfranchised populations as patients. The switch from fee-for-service to quality quality care is make improvement progress towards providing the
Great question. And I think the country is, and the medical system is is investing a lot in quality measures. We need to know that what you're doing actually works. If it doesn't work, you shouldn't be doing it anymore. No, and it's got to be across the spectrum. So whether you're in the hospital, whether you're in an outpatient clinic, we need that clinic. I think they're waiting to come into this room for another talk. So thanks for the question. I'm sorry I spoke too much. Our chief did send me signals. He's fairly new, I have to say that. He'll learn very quickly is there's some signals that stop you immediately. It's like, excuse me, the watch is now off. Stop. Right. So thank you all. I'm happy to step outside if you want to talk a little more to those who want to do it. Those questions. Thank you so much for the invitation.
And Dr. Levin, in the military, we have a tradition of showing our appreciation by presenting coins.
Good. So I'm going to say this. I love these. In my office, I've actually I finally said I used to have, she used to be Obama's chief of crisis communication out of the military. So she taught me very clear because I'd go into her room and she'd have all these hundreds of these coins. And I thought, oh my God, I want one. No, sir, you've got to earn this. So I really thank you. Come to my office and I hope you do come see the building downtown. It is an amazing building. You come to my office, you will see the coins and yours are there. This is my third one, so thank you.